So retinal artery occlusion is a disease on which there is occlusion of the retinal artery. Doesn't need more explanation. But what will be the source of this occlusion? It could be either an embolus present in the retinal artery, which can has two sources, two main sources. It can be either cardiac, so it will be the heart. Those who have heart disease can have like calcium embolus from the heart. Can be vegetations, especially those who have like endocarditis. It can be thrombus from the heart, like those who have artificial valves in their heart, and they will have more tendency to develop thrombus. Or there is a tumor in the atria called myxoma, atrial myxoma. They also could detach, leading to a thrombus. So this thrombus will pass from the arterial circulation until they reach the central retinal artery, leading to its occlusion. Also, the other mechanism, the other source of embolus can be from the carotid artery. So there is a carotid atheroma. There is cholesterol deposits into the carotid artery, and these deposits can cause narrowing of the carotid artery, which will lead to another disease called ocular ischemic syndrome. We will come to this later. And this cholesterol, there are deposits from the cholesterol, or plaques from the cholesterol will detach, or fibrinoplatelets plaques over the cholesterol plaque will detach, leading to occlusion of the retinal artery. So this will result in this thrombus. Or it can be narrowing of the arteries. This narrowing caused by deposition of lipids, cholesterol within the wall of the artery, leading to narrowing of the artery. Okay, so this will result in cessation of the blood supply to the retina. Occlusion of the central or retinal artery will lead to ischemia in the area of the retina supplied by this artery. So what will be the spectrum of this disease? It could be an occlusion of the branch retinal artery. So as we said, the branch retinal vein can be occluded. Also, the branch retinal artery can be occluded. So this will result in area of whitening, retinal edema and whitening in the area supplied by this branch. So it can be localized in a certain area in branch retinal artery occlusion, or it can be diffuse involving the whole retina, leading to what's called central retinal artery occlusion. So you see that the blood vessels are narrowed. You can see that the fovea appears reddish. So the reddish fovea due to the presence of choroidal circulation. And this is what's called cherry red spot. Cherry red spot. Also, it can be present with central retinal artery occlusion, but so the patient has pale retina, but since the patient is a little bit lucky, because he is one of the 15 or 20% of population who have cilioretinal artery. So this cilioretinal artery is a branch from choroidal circulation, and it was not occluded, so it will result in perfusion of the macula. So you can see that the retina is pale, but the central area of the fundus of the macula is perfused because of the intact cilioretinal artery. There is another association with the retinal artery occlusion, appears frequently in the exams, called the Susac syndrome. In Susac syndrome, there is a retinal artery occlusion, which is a branch retinal artery occlusion. So this is a kind of vasculitis which occur more common in females, leading to vasculitis of the retinal blood vessels, mainly the retinal branch retinal artery occlusion. Also affected the cochlear blood vessels, leading to sensory neural deafness. Also affected the cranial blood vessels, leading to encephalopathy. So this is the triad of Susac syndrome: branch retinal artery occlusion, sensory neural deafness, and encephalopathy. So if a patient would develop the central retinal artery occlusion or branch retinal artery occlusion, and he lost the vision, what we should do? What should we follow up this patient? Yes, because a minority of those patients can develop neovascular glaucoma. So it is still again a risk. And what is worse than a blind eye? It will be a blind, painful eye. So neovascular glaucoma can cause painful eye. So that's why we should always follow up those patients every year for development of new vascular glaucoma, even though has a very low percentage, maybe like 1%. This is unlike the vein occlusion, where the neovascular glaucoma is much more common. So the fluorescein angiography can be helpful in case if there is in doubt about the diagnosis, but actually we don't do on the spot. Like if the patient present with a branch retinal artery occlusion, we don't do fluorescein angiography because this is an emergency, and we will talk about the management right now. But later on, to make sure of diagnosis, for branch retinal artery occlusion or central retinal artery occlusion, it is simple, or it is like understandable that we would say the occlusion of the arteries. So the arteries, the occluded artery will not fill. There will be early masking of the fluorescence by the surrounded retinal edema. There could be late staining of the arterial wall, and in central retinal vein occlusion as well. So you can see that the seriochoroidal blood vessels or serioretinal arteries are filling, but the retinal artery themselves are not filling. So there is choroidal flush because of the filling of choroidal circulation. The short ciliary arteries are filled, but the retinal arteries are not filled. Even in the late stages, there will be staining of the vessel wall, but there is no filling of the retinal arteries. So what will be the treatment? First of all, it is an emergency. If a patient presenting to you with a central or a retinal artery occlusion, this is an emergency. We need to dislodge the thrombus, or our aim is to dislodge this embolus from the major artery to a small or a peripheral artery. So how can we do that? We can do that by different measures. First of all, ocular massage by a gonioscopic lens will be helpful to maybe dislodge the thrombus from the central or branch retinal artery to another minor branch. Doing paracentesis, inducing hypotony to the eye, will also be helpful to maybe dislodge the thrombus. Giving antiglaucomatous medications such as acetazolamide also induce hypotony, causing dislodge of the thrombus. Breathing into a bag, this will result in accumulation of carbon dioxide within the body, leading to vasodilatation of the blood vessels, which will also help in maybe dislodge the thrombus. So this should be done as early as possible, preferably within first hour or first 2 hours from the incident. This will give the better prognosis. But the presentation or the management, the more incidence of permanent visual loss. Okay, so let's say now the patient. So here in those patients, unlike the diabetic retinopathy or the vein occlusion patients, those are not emergencies. So we can work up the patient at our comfort, and we then schedule them for laser or anti-VEGF. Of course, in case of not emergencies like high-risk PDR, we can just schedule the patient for injection like a week later or 2 weeks later. But in case of artery occlusion, the order of management is reversed. So we manage the ocular condition first as an emergency. Then we do work up to see what was the cause of retinal artery occlusion, because we want to prevent it from reoccurring. So it will be the same to do CBC, to do cardiac consultation. So the cardiac consultation here is the most important, to do ECG, echocardiography, carotid duplex to check for the presence of carotid atheroma or ischemia of that result from carotid insufficiency, and always watch out for the development of new vascular glaucoma. There is also important term that we mentioned, which is the cherry red spot. Cherry red spot is the presence of red fovea associated or surrounded by pale retina. This is a differential diagnosis that you need to know. It can be due to acquired causes like central retinal artery occlusion, or macular hole, or commercial retiny, or kinine toxicity. These are the commonest causes that will result in the appearance of bright red fovea surrounded by pale retina, or in comparison to the retina. Also, there are some congenital diseases characterized by depositions of like mucopolysaccharides or mucolipids. These are metabolic disorders like Tay-Sachs disease, Niemann-Pick's disease. Sometimes they ask in the MCQs about what will be the race or the association. This disease is more common in Jews. So Niemann-Pick's disease is more common in Jews. Gangliosidosis also can present with a chariot spot. The other disease, which will be in close relation to the central retinal artery because it will be, or central retinal artery occlusion, because of the common pathology, will be the ocular ischemic syndrome. In the ocular ischemic syndrome, this disease affects elder patients. Those elder patients, 90% of them or more, they will be due to carotid artery insufficiency. So there will be like atheroma in the carotid artery that will cause occlusion of the lumen. So there will be limited blood flow through the internal carotid artery that will reach to the brain, and including the ophthalmic artery that is branched from the internal carotid artery, and including the central retinal artery, which is a branch from the ophthalmic artery. So it is as you can see from the name, it's ocular ischemic syndrome. It means there is ischemia of the eye, resulting in from decreasing blood flow that is coming from the retinal artery, from the ophthalmic artery, from the internal carotid artery. 80% of patients are unilateral, and the commonest pathology or the commonest etiology will be the atherosclerosis. Atherosclerosis will be narrowing of the arterial wall, leading to decreasing the blood flow. So what will be the manifestations of ocular ischemic syndrome? Those patients will present with dull aching ocular pain. So this is very common for those patients to have pain that they don't know what is the nature, and even when you check them, you don't know what will be the pain. They will also can present even by floaters, and you just say that it is normal floaters, and or you don't give much attention to these vague symptoms, but the signs here are more rewarding. So they will have ocular pain, gradual visual loss. This disease needs high index of suspicion. So what will be the signs that will be helpful to diagnose? Starting from the anterior segment. The anterior segment suffers from ischemia. So this will result in like involvement of every ocular structure. The cornea will be edematous. There will be increasing intraocular pressure, high intraocular pressure, especially if this patient developed neovascular glaucoma. Anterior chamber reaction, which has very important characteristic, that the anterior chamber, that there is flare more than cells. We know that the reaction consists of cells and the flare. Cells occurs more in inflammatory causes, but for the anterior chamber reaction or in the ocular ischemic syndrome, it will be more flare than cells. Also, this is for the anterior segment. For the posterior segment, there will be fundus hemorrhages, there will be narrowing of the arteries and dilatation of the veins. Narrowing of the arteries and dilatation of the veins. So there will be like there will be limited flow of the arteries, limited flow of the blood in the arteries due to insufficiency of the carotid, and there will be stagnation of the blood in the veins, leading to dilatation of the veins. Regarding the fluorescein angiography, so first of all, there will be delayed filling. So the arm to retina time, as I told you, it will be delayed. So normally it will be like 9 to 10 seconds. This could be like 20 seconds, for example. So there will be delayed choroidal, delayed arteriovenous filling, and delayed staining of the arteries. So you can see here, this is the arterial filling, and the arterial filling here, it takes too much time. And then there will be arteriovenous. You can see the lamellar flow of the fluorescein into the veins. And this is the late phase. You see the dilated veins, and there is late staining of the arteries. The arteries will show staining of the wall, and also there is some sort of macular edema in the center and staining of the disc. So the treatment here it will be like treatment of the same like diabetic retinopathy. So if there is macular edema, those patients should receive injection, and treatment is by treatment of the underlying condition. Like those patients have carotid insufficiency, they should be referred to a vascular surgeon. Maybe they will be candidate for carotid endarterectomy to remove the plaque, to remove the narrowed segment of the internal carotid artery, and do anastomosis of the two segments of the internal carotid artery. So those patients should be referred for carotid duplex, for cardiac workup, for possible cardiac for possible endovascular surgery, as I told you, by carotid endarterectomy. The next disease is the hypertensive retinopathy. So hypertensive, what is the effect of the hypertension on the eye? Hypertension can result in hypertensive retinopathy, or choroidopathy, or optic neuropathy. Okay, hypertension lead to retinopathy, choroidopathy, or optic neuropathy. Regarding the hypertensive retinopathy, the earliest sign in the hypertension is the arteriolar constriction. So the arteries or the arterioles will be constricted or narrowing, showing what's called arteriovenous necking. There will be like there is a neck between the arteries and the veins and the arteriovenous crossing. This will be the commonest sign in chronic hypertension. Okay. Regarding the hypertensive choroidopathy, the hypertensive choroidopathy occurs especially in young patients with acute hypertension. So who are those patients? Those patients who are pregnant, like in preeclampsia and eclampsia, hypertension during pregnancy, or patients who have malignant hypertension due to pheochromocytoma, or patients with renal disease. So what are the signs of hypertensive retinopathy or hypertensive? We will come to the signs of hypertensive retinopathy in the next slide, but for the hypertensive choroidopathy, what will be the signs? We could show what's called Elshing spots. Elshing spots are hyperpigmented spots with hypopigmented rim. You see, this is a hyperpigmented spot and associated with hypopigmented rim. This is called Elshing spots and represent areas of choroidal infarction. Okay, so this is called Elshing spots. Or there could be linear areas of hyperpigmentation overlying choroidal arteries. So you see this linear hyperpigmentation overlying the choroidal arteries. This is called the Séjourist streaks. Séjourist streaks, these are areas of hyperpigmentation overlying the choroidal arteries. Both of them occurs due to choroidal ischemia, which happens acutely, more commonly in patients with preeclampsia, eclampsia, pheochromocytoma, and renal disease. Also, it could be there is optic neuropathy. We said hypertension as one of the differential diagnoses of optic neuropathy in the neuro. So it could be the presentation of the optic neuropathy depends on the degree and the chronicity of hypertension. So you find optic disc swelling, flame-shaped hemorrhage, and cotton wool spots everywhere. So in severe hypertension, there will be flame-shaped hemorrhage and disc edema. The acute hypertension attack or acute hypertensive episodes can produce a specific signs of retinopathy called focal, intra-arterial, or intraretinal periarterial transulates. Focal, this white arrow. So there will be like translation from the arterioles. This will occur in the focal areas intraretinal. So these white areas are called focal intraretinal periarterial transulates. This was also asked before in the MCQs. Also, another sign of ischemia in hypertensive retinopathy is the cotton wool spots. You see, these are the blackish arrows. These are called cotton wool spots, which indicates the ischemia of a retinal nerve fiber layer. So if it asks in MCQs, where is the level? Why the cotton wool spots occurs? It occurs due to something called disruption or disturbance of the exoplasmic flow, which will result in accumulation of debris. This debris appears as cotton wool spots present in the superficial layer of the retina, which represent the ischemia in the retinal nerve fiber layer. If the hypertension is uncontrolled, then this will result in non-perfusion, ischemia. So this will result in microaneurysms, intraretinal microvascular abnormalities as well, dot on the blood hemorrhage, hard exudates, venous bleeding, and new vascularization. So it will be the same like diabetic retinopathy. So we are speaking about the spectrum of retinopathy. It will be, most of them will have the same manifestations like microaneurysms or hemorrhages or cotton wool spots or hard exudates. By the way, hard exudates, there is the cotton wool spots are sometimes referred to as soft exudates. Venous bleeding, intraretinal microvascular abnormalities, these are the signs of ischemia. And the management, of course, will be the control of the blood pressure. Another disease will cause retinopathy is called the sickle cell retinopathy. So sickle cell retinopathy is caused by sickle cell disease. It is one of the hemoglobinopathies. So the patients, instead of having normal hemoglobin, they will have some mutation in the gene responsible for hemoglobin formation, resulting in formation of hemoglobin S and hemoglobin C. These hemoglobin are abnormal hemoglobin. They will show sickle, they are sickle in shape. So this disease, again, is more common in African American. This is the third disease. We talk about the African American. And it will show abnormal hemoglobin. This is hemoglobin C or hemoglobin S. Resulting in this sickling will result in more instance of vaso-occlusive crisis. So this abnormal hemoglobin will be over each other, or will accumulate over each other, leading to occlusion of the blood vessel. There are some risk factors that will increase the liability for this occlusion or this aggregation of or sickling of the blood vessels. It will be hypoxia and acidosis. Remember when we talked about the carbonic anhydrase inhibitors, we said that it will cause metabolic acidosis as a side effect. So if a patient has hyphema, for example, due to sickle cell disease, he shouldn't receive carbonic anhydrase inhibitors, systemic carbonic anhydrase inhibitors, because it will increase the sickling. Okay, so in this case, carbonic anhydrase should be avoided. So what will be the manifestations of sickle cell retinopathy? How a patient with a sickle cell disease present in the retina? It will result in the manifestations of retinopathy due to abnormal hemoglobin and occlusion of the blood vessels. First of all, it can be non-proliferative. Non-proliferative, meaning that there is still no new vessels. It can present with one of two presentations. Salmon patch, it will be a result hemorrhage present in the fundus. This hemorrhage is not due to proliferation, not due to new vessels. One of the commonest tricks in the MCQs, they will present to you a case of intraretinal hemorrhage, which is called salmon patch appearance, and say that it is due to proliferation. No, it is non-proliferation or non-proliferative phase. The sunburst spots is another lesion which is present in case of sickle cell retinopathy, which appears like blackish lesion due to RPE hyperplasia. Sunburst spots. So remember, two spots or two patches, salmon patch and RPE hyperplasia. This is the non-proliferative sickle cell retinopathy. What happens if the patient is proceeding to the proliferative stage, meaning that there is occlusion, and this by vaso-occlusive crisis caused by sickling, and the patient developed ischemia and the new vessels? The new vascularization or the ischemia starts first by peripheral arterial occlusion and development of arteriovenous loops like that. These arteriovenous loops. Then we'll develop the C-fan neovascularization. This is a form of neovascularization taking the shape of C-fan. I will show you the C-fan right now. And these new vessels, they can bleed, resulting in vitreous hemorrhage, or can form fibrovascular membrane that can contract, leading to tractional retinal detachment. So these are the manifestations of proliferative sickle cell retinopathy: arteriovenous loops, C-fan neovascularization, bleeding from these blood vessels leading to vitreous hemorrhage, or tractional retinal detachment. So what will be those patients looks like in fluorescein angiography? There will be filling of the new vessels and extensive peripheral capillary non-perfusion. You see here, this area of the retina, there is capillary dropout, non-perfusion. And the blood vessels are trying to perfuse the peripheral retina, so they are arborized like that, making this pattern of C-fan. So this is the C-fan neovascularization, and there will be leakage from this C-fan neovascularization. And this what will make these blood vessels more liable to bleed and more liable to cause vitreous hemorrhage and tractional retinal detachment. So what will be the management in such cases? It will be laser, to do laser over the ischemic retina. And if the patient has developed vitreous hemorrhage or tractional retinal detachment, the treatment will be parthoplanopetrectomy. Okay, so this is the sickle cell retinopathy. I hope that this is clear. And for another disease is the retinopathy of prematurity. It was already covered in the pediatric ophthalmology, so you can refer to the classifications and the management of different stages of retinopathy of prematurity from the pediatric ophthalmology lecture. The next disease is the Coats disease. So what is the epidemiology and the pathogenesis of Coats disease? Coats disease is a disease of childhood. It is usually present in between the age of 6 to 8, but it can present up to 15 years old, and more common in boys, like 85%, more commonly to be unilateral, and more commonly to be sporadic. So there is no systemic associations. So Coats disease is another disease characterized by telangiectasia, or we will now cover a group of diseases characterized by dilated abnormal blood vessels or telangiectatic blood vessels. One of them is the Coats disease. So remember this boy, he is a boy present with, he is usually a boy, usually between around 8 years old, usually unilateral and sporadic with no systematic association, and present with this manifestation. What we can see here, the left eye show leukocoria, because these patients will show unilateral yellowish-white subretinal exudates. These subretinal exudates, what will make the patient looks like having leukocoria. Remember in the differential diagnosis of leukocoria in the intraocular tumors, we said that the Coats disease is one of the important differential diagnoses. So what is the pathogenesis? What happens? Due to unknown cause, those patients will develop abnormal telangiectasia. They will show dilatation of the blood vessels, like venous dilatation, like showing microaneurysms and exudation of this hard exudates. And this exudation can be very massive, up to, it can result in retinal detachment, exudative retinal detachment. So you see the dilated blood vessels and aneurysms with exudative retinal detachment is what is causing leukocoria. So there is another variant of Coats disease which appears with dilated blood vessels or telangiectasia, but it is just temporal to the macula. So you see there are here very fine blood vessels, dilated blood vessels, temporal to the macula. This is not Coats disease. Coats disease tends to be peripheral, but in the central, it is called macular telangiectasia type 1 or MAC-TEL type 1. So don't confuse between this, or not every dilated or telangiectatic blood vessels will be a Coats disease. If it is central near the macula with exudation like that, it will be a MAC-TEL type 1. So let me show you like a quiz. So you see here, there are two images, this image and this one. One of them is a Coats disease, and so let me just make my pen like this is image number 1, Coats disease, and number 2, Coats disease or retinoblastoma. So this is Coats disease or retinoblastoma, and this is Coats disease or retinoblastoma. So what do you think? Number 1 what? And number 2 what? So one of them is Coats disease and the other is retinoblastoma. And I already said the answer. Yes, exactly. As you said, number one is the Coats disease, and number two is the retinoblastoma. And why? I guess that's also you know the answer because of the blood vessels. You check here the blood vessels, you can see the telangiectasia, you see the microaneurysms. So this is an exudative retinal detachment caused by subretinal exudation in Coats disease. While here in the retinoblastoma, there is a subretinal mass, and this retinal detachment is due to the subretinal mass, and the blood vessels here looks normal. Okay, the other difference also between the both of them that the due to the exudation in the coastal disease, it will appear more yellowish. So it will be doesn't always have to be leukocoria. It can be xanthocoria. Xanthocoria, there is yellowish red reflex, but in retinoblastoma, it's more likely to be leukocoria. The third difference between the Coats disease and retinoblastoma will be the age of presentation. So usually the retinoblastoma will present at below 2 years old, while the Coats disease will present at older age, usually around 6 to 8 years old. Okay, so this is the Coats disease. How would we manage a patient with Coats disease? Laser photocoagulation to the ischemic retina in order to trying to not only the ischemic retina, but trying to obliterate the new vessels. So obliterate, the aim of treatment here is to obliterate the telangiectatic blood vessels by laser photocoagulation or by cryotherapy. Injection of triamcinolone acetate will be shown to be very beneficial for cases with massive exudative retinal detachment. Anti-VEGF is controversial. Like some studies say that it should be given like an adjunctive treatment. Other studies say that it will be associated with higher incidence of complications. So still there is no consensus about the anti-VEGF. Vitreoretinal surgery should be also done for cases where there is detachment or like macular detachment or exudative detachment, maybe also associated with external scleral drainage to try to drain the subretinal fluid. Enucleation can be, unfortunately, this disease has a poor prognosis. So sometimes some of those patients may develop severe painful eye. So in this case, treatment should be by enucleation. Okay, another variant of telangiectatic diseases is called MACTEL or macular telangiectasia. So macular telangiectasia is a condition where there is dilated blood vessels within the macula, unlike the Coats disease where the abnormal blood vessels are present in the periphery. The MACTEL has three types: type 1, type 2, and type 3. Let's see what are the differences between them. In type 1, it is unilateral. Please concentrate with me because these are the areas for the MCQs. Type 1 is unilateral. In type 1, it is more common in males than in females, more common in young than in old, and appears with a circinate exudate, like that. So when we see a patient doesn't have any signs of diabetic retinopathy or any other ocular diseases, and we find some sort of circination, some sort of macular exudates. So again, suspect that there is an inciting focus present in the macula. So this will be like macular telangiectasia. So this will be evident by fluorescein angiography or more evident by the OCT angiography. So you will find there is hard exudation and more common unilateral young male. This is more common to be MACTEL type 1. Type 2 is the most common, and it is bilateral. And in those, the gender male equals to females, and onset usually between the 40 to 60 years old. So those patients tend to be old. So they have been linked to vascular diseases that appears in old age, like diabetes or hypertension. And they can be complicated by the subretinal neovascularization. So you see here, you can see those patients have like this appearance of grayish reflex. So they will those patients can present with a scotoma or metamorphopsia, and when you see them, you will find that the red reflex doesn't look normal, doesn't look like the normal appearance of red reflex. There is like a grayish discoloration. So those patients, when you do fluorescein angiography, you can find the presence of leakage at the area of the macula. And this leakage typically to be more temporal in the fluorescein angiography. So this goes with the MACTEL type 2. So to differentiate again, type 1, it is unilateral parafoveal telangiectasia in a young male child. Type 2 is bilateral parafoveal telangiectasia in an old adult. Okay, that can be complicated by subretinal neovascularization, and for those, if it develops a subretinal neovascularization, then they can be treated by the anti-VEGF. Type 3, it is very rare and very rare, and it is bilateral in males equal to females, and there is occlusion of the perifoveal capillaries, leading to progressive visual loss. So here there is, you can see the perifoveal capillaries, there is occlusion with dilatation. So this disease is very rare, so it is not very important, but the most important is type 1 and type 2. Okay. So type 1 present with cercination. Type 2 present with grayish appearance and sometimes crystalline deposits present in the fovea. And type 3 present with occlusion of the perifoveal capillaries. So those patients, as I told you, will present with metamorphopsia or scotoma. And the treatment will be so you can't treat, like you can't do laser in the center of the fovea. So you just treat the presence of the CNV or subretinal neovascularization if it develops by the anti-VEGF injection. There are some other treatments under trial, but still no consensus on the treatment. The other treatment or the other disease caused also by, it is a peripheral occlusive periphlebitis called the Ehlers disease. Ehlers disease is a disease characterized by idiopathic occlusion of the peripheral veins or occlusive periphlebitis. The race here is very important, or the epidemiology again is very important, and it will be the key to solve the scenario in the exam. It is more common in young male Indians. Again, more common in young male Indians. And it is more commonly to be bilateral and more commonly to be asymmetrical. So why we know that, or it is known that tuberculosis has a high incidence in India. And so remember that this disease is having association with tuberculosis. So this disease, or the Ehlers disease, is being more common in patients with tuberculosis or have hypersensitivity to tuberculous antigens. And those patients, this is also another clue in diagnosis of this disease. So what will be the presentation? Those patients in the scenario, usually they will present with floaters. So just to put this disease together with other diseases that may present with floaters, like ocular ischemic syndrome, like paraplanitis. So it can be either present by floaters or present with vitreous hemorrhage from complications. Also, those patients could have some systematic neurological features, and they could have mild anterior uveitis. Regarding the fundus picture, what can we see here? You can see that there are like ghost blood vessels in the fundus, in the periphery. So there is peripheral periphlebitis. There is sheathing of the blood vessels. There could be superficial retinal hemorrhage or cotton wool spots or scars. It could also lead to branch retinal vein occlusion. As we told, it is periphlebitis. So it can result in occlusion of the veins, branch retinal vein occlusion, and lead to peripheral capillary non-perfused retina. So This peripheral perfusion will lead to the ischemic process. The ischemia will result in new vascularization, leading to vascular shunts, tortuosity of the blood vessels, new vessels. These new vessels will result in hemorrhage, causing vitreous hemorrhage, which is one of the commonest presentation. 1/3 of the eyes will present with vitreous hemorrhage. Okay, so you see the vitreous hemorrhage here due to the new vessels. Also, new vascularization can present in the elsewhere or present in the optic disc. So what will be the treatment? Steroid is controversial. So it could be beneficial, but in sometimes also there is no consensus on the use of the steroids. Antituberculous treatment, should the patient be tuberculous, they should receive the antituberculous treatment. Laser photocoagulation to the ischemic areas. So as I told you, the triamcinolone acetate or the steroids in general will be controversial. Anti-VEGF injection to prevent the new vascularization, and the vitreoretinal surgery if the patient develop like tractional retinal detachment or a persistent vitreous hemorrhage. Okay, this is another disease called the Ehlers disease. Finally, some other retinopathy that can occur in the retina called the Purshar retinopathy. So what is meant by Purshar retinopathy? Purshar is a scientist who discovered this disease. He discovered him in the first instance, like maybe 100 years ago, in a patient who had a tree fell on him. So the tree fell on him, and this tree result in head trauma. And this head trauma showed a presence of ischemia in the retina in the form of multiple cotton wool spots. So presence of diffuse multiple cotton wool spots secondary to trauma, that can be trauma, head trauma, or chest compression. It's called Purshar retinopathy. So Purshar or the classic Purshar retinopathy is a traumatic retinopathy, either head trauma or chest compression, long bone fracture or crashing injury, orthopedic surgery or weightlifting, battered baby syndrome or the shaken baby syndrome, barotrauma from the altitudes. So the classic or the Purshar retinopathy is due to trauma. This is very important. After that, after Purshar, many diseases have been associated with the same picture of multiple widespread cotton wool spots. So they named it Purshar-like retinopathy. Purshar-like retinopathy is when there is cotton wool spots, non-traumatic. Like the most important is acute pancreatitis. Don't forget that for MCQs. Or other kinds of chronic diseases and tumors like pancreatic carcinoma, chronic renal failure, connective tissue diseases, hemolytic uremic syndrome, orbital injection, thrombotic cytopenic purpura, embolism, preeclampsia, hemolysis, adenocarcinoma, Hodgkin lymphoma. So all these diseases will present with the same picture. So what is the same picture? Is it only cotton wool spots or others? The cotton wool spots is almost universal. It will be the most abundant feature, occurs in more than 90% of cases. However, other features could also occur like retinal hemorrhage in 65. And there is another pathognomonic feature called Purshar flecken. Purshar flecken is this one. This is not a hard soft exudate, or this is not a cotton wool spot. This is called Purshar flecken. This is a polygonal, so it will look like that. It will be polygonal areas of retinal whitening with clear demarcation line between the affected retina and the normal retinal vessels. So there will be clear demarcation area between it and the retinal blood vessel, like that. So it will be related to blood vessels, but there will be clear demarcation area between it and the normal retinal blood vessels adjacent to it. Okay, so this was asked before. The Purshar-like retinopathy was asked before in the advanced ICO exams. So I hope that you know what will be its etiologies and manifestations. Okay, so these are all the vascular retinal diseases that we will that we cover today. So thank you very much for your attention. I hope that you enjoyed the lecture. I hope that the chapter of the retinal vascular disease is now becoming more easy for you. And speaking about the retina, it gives me a pleasure to announce that we are conducting a new course for retinal guidelines by our medical retina expert, Dr. Amin. He is running now the medical retina investigations course, and starting like after 3 or 4 weeks, he will conduct a new course for retinal guidelines. The retinal guidelines is basically how would you think in a diabetic retinopathy or retinal vein occlusion based on guidelines. There are plenty, hundreds of studies that discuss the medical retinal diseases. So, and when you are just thinking about the medical retinal case, you just got confused because there is a gap between the studies and the practice. So this course, I believe that it will be very beneficial to fill in this gap, to make you oriented about how to have a step-by-step approach to manage different medical retinal diseases. So, and I believe that it will be a huge asset for your understanding to the medical retinal problems. So my much appreciation to Dr. Amin for filling in this gap and to provide such high quality content that will be very, very helpful for any ophthalmologist, whether it is just for practice or for the exams. Thank you very much for your attention. I hope that you enjoyed the lecture. Do you have any question? I see a question above. Dr. Tamim, excuse me, doctor, if a patient post extracapsular cataract extraction with anterior chamber IOL, just hold on, please. It might have like a phone. Okay, so sorry for the interruption. Excuse me, doctor, if a patient post extracapsular cataract surgery with anterior chamber IOL due to vitreous loss, 6 months, Irving gas, which better to use triamcinolone or quinacort intravitreal alone, or combined with either of them with Avastin? Okay, first of all, we need to know what is the pathology. What will be why the patient developed Irving gas? Is it only the vitreous loss, or does the patient has, for example, concurrent uveitis or diabetes or other risk factors? So this should be put in mind. Second of all, we need to know whether there is still vitreous, in the anterior chamber or not. So this also should be addressed. If there is still vitreous, this should be removed. This can result in refractory cystoid macular edema. Also, then after removing all these factors, then we can check for the treatment. So those patients usually receive the non-steroidal anti-inflammatory drugs, and if they are not effective, we can either inject steroids or anti-VEGF. And I can tell you whether to use anti-VEGF or steroids, but actually I would leave you to reach this question from Dr. Amin himself. So you can find the link of the choroidal of this the link of this course. There is a sample lecture. This sample lecture, please watch it. He will discuss, or he is discussing in this free sample lecture, the management of post-operative cystoid macular edema in the Irving-Guest syndrome based on the studies. So there are several studies. Some advocate the use of anti-VEGF, some advocate the use of steroids. So what should we use? Here, Dr. Amin will answer you. So please watch the sample lecture by Dr. Amin. No problem, Dr. Iman. Okay, thank you very much. Does anyone have any question? Okay, thank you. So next time we will go through the macular diseases. Hopefully we will finish the macular diseases and the retinal and macular dystrophies. Hopefully it will be maybe a long lecture. I intended that we will finish the course this week. So will try to do my best, and you also do your best in order to try to finish everything this week. So, but just study, don't wait. So you have 2 days, like till Monday, to start to study the retinal vascular diseases. And but I hope that it is much easy now. Okay. Thanks a lot. Okay, thank you, and see you next Monday for the macular disease.